Good morning and welcome to the November 2nd, 2021 meeting of the Lane County Board of Commissioners. This morning, we're starting our meeting actually with a joint meeting of the Board of Health and the Board of Commissioners. So we'll begin that agenda. For those of you, if there are those of you that are here to make public comment, we understand your schedules might not allow you to wait through this meeting, so you are more than welcome to make any public comment you feel appropriate and necessary at this first section if you can't join us when we convene the regular board in a bit. So for this joint meeting, are there adjustments to the agenda? Seeing none, is there emergency business? Seeing none, that brings us to item 3, public comment. To the public watching this meeting, when you registered to watch in this temporary, seemingly not so temporary virtual format, you were registered in our system as attendees. Attendees are webinar participants who are audience members viewing the meeting. Your microphone and webcam are automatically muted. However, during public comment periods, such as now, we are opening the meeting for your comments. If you wish to participate in public comment, please raise your virtual hand to be recognized by our moderator, Ms. Jones, by pressing the hand icon. When public comment begins, she will call names. When your name is called, you will be provided up to 3 minutes for public comment. We do this so everyone has the opportunity to comment. When your 3 minutes are up, I will let you know, and I will ask you to wrap up in a few seconds if you possibly can. And you will go back to muted status so the next person can be called. You may then continue to watch the webinar as long as you choose, and we will try to give everyone who wants to present that opportunity to do so. Having said that, Ms. Jones, are there any people that would like to make public comment at this time?
Thank you, Chair Bernie. Yes, I do see quite a few hands raised, actually. Point of clarification, this is our only public comment time during the day. So if you did sign up for public comment and you'd like to present public comment to the board, this is the time you would do it. Please only press your hand icon once, because if you press it twice, it puts your hand down. It is a toggle. I will begin our public comment this morning with Daniela Marino, followed by Michelle Zuartes. Daniela, I will unmute your microphone to begin your public comment.
Hello, board. Good morning. This is Daniela Marino. I am in absolute opposition to the vaccine mandates and the massive application of the experimental COVID-19 vaccine. As I stated last week, this vaccine operation is the largest drug deal of history. Thanks to the commissioners for not applying these illegitimate mandates onto our Lane County community so far, and I hope that you'll stay on that path. Key numbers in our state: survival rate is still over 99.98%. 2 infants between 0 and 9 years old and 3 kids between 10 and 19 years old died with COVID, and they all had pre-existing conditions. Same numbers as I've been reporting. Over 89% of total deaths were over 60 years old and had pre-existing conditions. I want to respond to Dr. Luque on his comments about hospitalizations. Oh my goodness, this morning, hospitalizations. And I want to say that they're important too, but less than 0.005% of the population in Oregon have been hospitalized with COVID. So that doesn't grant a state of emergency, does it? I keep hearing that stories are important, so I brought you some stories directly from the VAERS report. You all have this in your inbox. I sent it to you weeks ago. So I just picked some, and these are all from the state of Oregon. First, quote, "My husband died of a sudden massive heart attack. He was one of the 2 teachers who died after the Moderna vaccine, 2nd dose, and 3rd teacher had a stroke." Second quote, "Patient died of heart attack unexpectedly the following the vaccine." 3, quote, "Patient stopped breathing 5 days after the vaccine. He was taken to the hospital and put on ventilator in intensive care. He died 6 days after." 4, quote, "Following 2nd dose, developed extreme fatigue, inability to swallow, liver and kidney failure, was diagnosed with DRESS syndrome resulting from reaction to vaccine, continued to decline, developed bleeding in the lungs, and died due to multi-organ failure. 5, quote, patient presented 3 weeks after vaccination with massive bilateral, femoral, and portal visceral thrombosis. Taken to surgery, thrombosis progressed, and patient died after 2 days. 6, and this is the last one. I got the second dose vaccine and had flu-like symptoms, which lasted for 12 hours and resolved. About a week later, I started dragging my foot and had left leg weakness and pain. I also noticed I was developing slurred speech and decreased hearing. My lung functioning is now at 50%. I'm unable to write legibly. I have feeding tube, and now I have to be in a wheelchair. I'm aware that the time is running out, and I will wrap it up. I was diagnosed with rapidly progressive ALS.
Your time is, Ms. Marino, if you could wrap up in just a few seconds, please.
Yes, sure. So this last story, she says, up until this first vaccine, I was working as a physician, treating COVID patients in urgent care, and I am now confined to a wheelchair. And then, yeah, I'll wrap it up right there. Thank you. No mandates.
Thank you.
Thank you for your public comment. Our next speaker is Michelle Zuartes, followed by Terrence McDonald. Michelle, I will unmute your microphone and you may begin your public comment. Michelle, I show you are self-muted. There you go.
Okay, thank you. Yes, good morning. Thank you. My name is Michelle Zuartes. I'm the field supervisor for the U.S. Fish and Wildlife Service's Oregon Coast Field Office, located in Newport, Oregon. And I'm just reaching out to all of the coastal county commissions to make sure that everyone is aware of discussions that are going on right now about the potential reintroduction of sea otters to the Oregon coast. At the end of last year, in the Omnibus Appropriations Bill, the U.S. Fish and Wildlife Service received a directive to study the feasibility and cost of reintroducing sea otters to the contiguous states of the Pacific coast. And we are in the process of completing that report now. It's due at the end of this year. We are aware that there is some confusion because there's 2 different feasibility studies going on right now. There is also an organization in Oregon called the Alaka Alliance, a nonprofit organization that recently released a feasibility study on sea otter reintroduction. Ours is independent of that. We are looking at the potential for reintroduction from biological, socioeconomic, and legal standpoints. We have been conducting stakeholder interviews to make sure that we are able to convey to Congress the concerns and perspectives of Oregonians on this issue, and particularly those in the coastal communities of Oregon. I want to emphasize it is a feasibility study. We're looking at whether this is an achievable action. We are not recommending whether it should occur. It is not a proposal to reintroduce sea otters at this time. So just wanted to make sure that you all were aware in case you get questions from any of your constituents, and give you the opportunity to contact me if you have any questions about this whatsoever. And that's all I have at this point in time.
Thank you for your public comment. I will now call on Terrence McDonald, followed by Chrissy Rossino. Terrence, I will unmute your microphone and you may begin your public comment.
Chair Bernie and commissioners, thank you for the opportunity to speak this morning. My name is Terrence McDonald. I'm the director of St. Vincent de Paul Society of Lane County. And as of yesterday, I have been a full-time employee of St. Vincent de Paul for 50 years. I've been the executive director of the organization for 37 years. And during that period of time, I'm happy to say that we've always had a very cordial and healthy relationship with our public partners throughout the United States. So I was shocked last Tuesday to find that Commissioner Bosevich felt that we somehow were doing things that were spurious or not appropriate. And that had to do with the public bidding process associated with contracts for services in Lane County. So one number he came up with was that we had received $4 million worth of grants or awards for services from the county in the past 2 years. When we checked our records on that over the last 2 audited years, we found that we could not find that number anywhere. We found a larger number, but we did not find that number. The second one is we also indicated that through contract amendment, that particular number had grown to 43 million. Again, over a 2-year period of time, we had no way of figuring out where that number came from either, even if you encountered the amendments that were going forward as part of the discussion. Basically, that would be about 1/3 of our operational budget, which is definitely not what we have with Lane County. But the last part was the part that bothered me most, and that was associated with contracts and how we acquire contracts from the county. We go through the regular RFP process on a regular basis with Lane County. And in certain circumstances, we actually decline to bid on projects, such as the project Room Key, which is a very large contract, $2.213 million worth of contracts for that program to house homeless individuals in motels. We actually, along with many other of our partners in the community, went out to look at that project, to bid on that project, and declined to bid on that project because we felt like it was not something that we should necessarily expand our services to. We were then approached by the county to go after that contract, and we did, somewhat reluctantly, to go ahead and bid on that project. We've always taken the position that we do everything above board, according to the rules, in a public way that I think is a benefit to all of the community out there. I was disappointed by those comments, and if there is something that we're doing that is immoral or improper, I would definitely like to know what they are so that I can bring it forward and correct those behaviors. Thank you.
Thank you for your public comment. Our next speaker is Chrissy Renault, followed by Mike McFadden. Chrissy, I will unmute your microphone and you may begin your public comment. Chrissy, I show you are self-muted.
Can you hear me now?
Yes.
Okay, thank you. I am sorry, I apologize. I'm a little nervous. I've never actually spoken before, but I just wanted to take just a quick minute or two because I wanted to speak about what happens when a broken system can fall when erring on the side of safety. Prior to moving here in 2005, I lived in Kelso, Washington. And that was the first time that I noticed that a system had really begun to fall and break apart. That was the Child Services Division in the area. So I began a nonprofit organization called Scream Louder, and together with several concerned parents, we helped fix and eradicate that issues that were taking place there in the Child Services Division. So this is the type of thing that happens when a system becomes corrupt and broken. It is the responsibility of every parent, every person to rise up and fix a system. In August of 1999, you may be familiar with this story, but I was pregnant with my daughter, Serena, and I was visiting a family in Mexico. While I was there, I went into preterm labor, and upon leaving the hospital, the staff and even Border Patrol had assured me that Serena would have dual citizenship. What they didn't know is that a child of 2 American parents is not automatically granted citizenship. Due to this confusion about the legal rights for individuals and the constantly changing laws, it ended up resulting in improperly filed paperwork, and Serena became stateless. That is a term that is used to describe a person that does not actually have a country. So according to both the US government and the Mexico government, Serena simply did not exist. After 9/11, more rules and regulations and laws were created. Life became much more difficult for Serena. She was treated as a terrorist. She was put on the no-fly list. Her health care was terminated. Her education was questioned. Her child care was revoked, and her ability to live a normal life was completely shattered. International fame of her situation left her absolutely no privacy at all. Constant psychological testing and tracking gave her an identity crisis, and she began to suffer PTSD, which took 15 years of bureaucratic red tape to break through and fix her situation. She's now 22, and she is still afflicted with PTSD that is caused by a broken and failing system of rules, laws, and regulations and mandates that were put into place intending for safety. Today, because of these same similar rules and mandates and defying current laws, school children will will suffer the same affliction in the name of safety. These children are being objectified. Their rights are being removed before their very eyes, and they are being told that they have no autonomy over their own bodies and what goes into them. A vaccine which has had no long-term testing at all to ensure their safety. These kids don't even have the right to their own breath. Their identities are being stripped from them and their voices are being removed. There is no doubt that implementing widespread abusive and controlling measures against every civil liberty that these children have that are endowed to them by their creator can cause irrevocable harm as well as long-term psychological damage. All over the virus that we are currently going through, which has a mortality and contagious rate of tuberculosis, and all in the name of safety. I cannot take part in the abuse of children, and if it causes a mobilization of other parents to take down any system that is working against them and harming them, that is the job of we the people. It is the very foundation that this country was built on, and I would have to help out with that. Thank you so much.
Thank you for your public comment. One moment, my screen changed. I will now call on Mike McFadden, followed by Harry Sanger. Mr. McFadden, I will unmute your microphone and you may begin your public comment.
Good morning, Chair and Board of Commissioners. Can you hear me okay?
Yes.
Okay, thank you for the time to speak this morning. I also am speaking this morning because I want to thank Hybrid Real Estate for their partnership with Looking Glass Youth Services to set up a transitional living program in a renovated apartment complex for unhoused teen boys. I think that this kind of project is critical service for all sorts of at-risk youth who are transitioning into adulthood. And so I just really want to thank those two partners for bringing this project forward. But that said, I think that, we need so many more than just one apartment complex, and it's going to take the buy-in and the participation of a whole community of partners and not just these two leaders. When I aged out of foster care in 2005, bound for university, I became homeless and lived for 2 years in Springfield in a van on the streets and couch surfing around. And it took me, with everything going right in my life, about 8 to 10 years to even achieve financial stability and get out of, jeopardy and living hand to mouth and paycheck to paycheck. So this kind of a service really does make a huge difference for whether it's unhoused youth, foster youth, all sorts of different people at risk. I can even see this really being important for people of all ages. I really think, and I'm glad to be addressing you as the Board of Health also this morning, that the housing crisis is a public health crisis. And so I really want to see us deploying more of our public health resources towards, tackling the crisis. There are all sorts of people who get trapped in bad and abusive situations because they fear being unhoused and they have nowhere else to go. And so there's just a lot of intersectionality between all sorts of problems of all different age groups that are tied into housing instability and uncertainty. So thank you for your time this morning and really hope to see us really begin to dig deep on this issue. Thank you.
Thank you for your public comment. Our next speaker is Harry Sanger, followed by Tressa Beaver, and then I show that is our final speaker for public comment. If you did sign up for public comment, please raise your hand and I will call you after Tressa Beaver. Mr. Sanger, I will unmute your microphone and you may begin your public comment.
Thank you. Hello, Chair Bernie, County Commissioners, and administrative staff. Thank you for providing the opportunity to speak this morning. I don't know how many of you saw last week's Eugene Weekly, but beside people not wanting to move the fairgrounds, people concerned about the negative impact of state mandates on land use through House Bill 2001, and transparency issues in 4J, there was talk of lower vaccination rates in our BIPOC neighbors. Black Girl from Eugene recognizes, quote, "This country is quickly dividing on many, many issues into the vaccinated and not vaccinated. When the conversation of equity unquote. When the conversation of equity in government mandated healthcare comes up, the fallback is on historical injustices, particularly the Tuskegee experiment. We should not gloss over the deep distrust of our government and institutions fomented by the CIA running crack into urban ghettos, or more recently, the constant barrage of hate against the former president, followed by those same pedants clutching their pearls over "Let's go Brandon" cheers. The way we're looking at this is broken. Another article in the latest weekly claims Jay Bozovich was being insincere by bringing up racial discrepancies in vaccinations, leading to inequity in county hiring policies. Everyone, right of center, is tired of being gaslit when it comes to critical race theory-based manipulations of the conversation. Silver Mogart, vice president of Eugene's League of United Latin American Citizens, is quoted as saying about Commissioner Bozovich, quote, "He shouldn't be speaking for the BIPOC community," that, end quote, that he shouldn't, quote, "speak on their behalf because he hasn't put in the work," end quote. We need to stop promoting this anti-American rhetoric. Commissioner Bozovich was publicly elected to represent all of the constituents of West Lane County, BIPOC or otherwise. I don't know Commissioner Bozovich's ethnicity, but supporting the poisonous logic that because his skin appears white, he can only represent others whose skin appears white is a root cause of the division that Miss Elliott identified in her column. We need to stop pushing these culturally Marxist ideals and embrace America as the melting pot it is. Commissioner Bozovich exposed your hypocrisy, that equity is only important when it serves your agenda. The county's vaccine mandate means that less BIPOC applicants for county jobs will be considered due to the lower percentage of BIPOC residents of the state and county being vaccinated. You callously dismiss this fact because there just aren't that many BIPOC constituents, but I remind you that there also aren't that many young people severely impacted by COVID. As you constantly iterate, though, even one is too many. Why is even one BIPOC candidate made ineligible for a county job because of vaccine status? Not too many. Thank you.
Thank you for your public comment. Our final speaker today is Tressa Beaver. Tressa, I will unmute your microphone and you may begin your public comment. Tressa, I show you are self-muted. There you go.
Can you hear me? Thank you so much for taking the time to hear my public comment today. I am here today to give public comment on the concerns I have around these vaccine mandates, these vaccine passports, and vaccinating our children. This is obviously a completely tyrannical move by our government. It is well known that every single media source out there is owned by Time Warner, who is owned by the Rockefellers. It is completely unacceptable to be controlled and manipulated by these tyrannical people who think that they can rule our lives. No, absolutely not. To have business owners and businesses across the United States and in Oregon being positioned to uphold these governors' rules, mandates, and regulations as if it's a law to mandate these vaccines that are harming our people, killing our people, injuring our people. is unacceptable. I demand that you stand up for the public, for our people, and stop these mandates. Now, thank you.
Thank you for your public comment. Chair Bernie, that was our final speaker for this morning, so I will return the meeting to you.
Thank you very much. And I want to thank all 7 of you who spoke to us. In fact, we're now in a bit of a quagmire. We were supposed to have a semi-annual Board of Health report. We have our staff standing by, and yet we also have do not then have the opportunity for remonstrances when those who were good enough to take the opportunity to provide public comments and exercise their democratic rights did that. So I have to ask Ms. Gaffney, Mr. Ludke, or Dr. Ludke and Dr. Warren, are you willing to allow board remonstrances while we have the public commenters online? Are you able to delay by 10 or 15 minutes this report or no?
Chair Bernie, I am looking at Dr. Warren, and I know based on our conversation agenda setting last week, we can be flexible. So yes, I think it makes sense for those remonstrants to occur, and we will stand by.
Ms. Gaffney, Dr. Warren, thank you so much for that. Commissioners, we're going to have remonstrances if you would like, to those who made public comment out of courtesy to them. Are there any commissioners that would like to start that process? Yes, Commissioner Bozovich.
Thank you. First, I want to address Terry McDonald's comments. I think Mr. McDonald was mistaken in that I was criticizing St. Vincent de Paul. My criticisms were more addressed towards county staff and our contracting processes. I chose to use them as an example because we had a contract amendment in front of us that day that was extending a contract well beyond the original time period and contract amount. I will be willing to send Mr. McDonald my spreadsheet with the dates of the contract amendments and award grants and extensions, if he would send me his email. I just don't have it. But I do have a spreadsheet and all the backup contract awards that we made in 2020 and 2021 to that particular vendor. And it totals $43 million. And what I stated was 4 million of that was done in a competitive RFP process. The remainder was contract amendments or sole source or sole bidder contracts. That to me is a criticism of our contracting process as a county. And I brought up the example of Travel Lane, where we got into a very comfortable relationship and just were continually extending their services for the use of our transient room taxes. And it was a clarion call to our staff to maybe start looking more carefully at how we are contracting with all of our local nonprofits to make sure we are being competitive and we are being accountable. And that was my concern in bringing that up. If you go back and look at some of my comments in past meetings about St. Vincent de Paul, they have been very favorable about the programs you've offered. So please do not think this was a criticism of St. Vincent de Paul. This was a criticism of loose contracting practice and a need for better contracting and more accountability and measurability. And that's what I'm looking for in bringing that up, was that there are several contracts in that spreadsheet that the current dollar amount is multiple times, over 1,000% in one case of the original contract. That just does not make proper sense. So that was what my issue was there. And along with that, while I have a moment for remonstrance, I had to ask our staff for public records requests to get some data. Speaking of, I apologize for that. Speaking of the issue of race and vaccination, I still have not received a response to that public records request or the data. And I sincerely hope that I get a response fairly soon, because it was time critical information. So it just bothers me that I had to make a public records request to my own organization for data, and it bothers me that I haven't received a response.
Thank you, Commissioner. Commissioner Buck?
Thank you, Chair. I raised my hand early when Commissioner Bozovich was speaking, only because it was regarding St. Vincent de Paul. And whenever there's a discussion regarding St. Vincent de Paul, it is my responsibility to declare a potential conflict of interest, as I'm related to the Executive Director of St. Vincent de Paul. If there are future discussions regarding contracts with St. Vincent de Paul, I would prefer them be on the agenda so that I can properly recuse myself from those conversations. Thank you.
Thank you, Commissioner. Are there any other commissioners that would like to make remonstrances or other issues? Seeing none, and knowing that we have staff waiting, I would just like to again thank everyone on all of the issues, from the vaccination issues to the reintroduction of sea otters, to the western coast of the United States, which I know that sounds dumb, but I'm really excited about that. To kudos really for hybrid real estate. That's a big deal. I know it's a one-off, but it's such a good demonstration of a public-private nonprofit partnership to deal with certain pieces of housing issues that certain populations are having. So for all of you that commented and brought up multiple issues, thank you very much. Did I miss any commissioners before we move on? We are now on item 4A of this joint meeting, which is a semi-annual Board of Health report. And to make it, we have Karen Gaffney, Dr. Patrick Ludke, and Dr. Jocelyn Warren. And thank you again for your flexibility and accommodation.
Chair Bernie, we are happy to be flexible. And Dr. Warren, I was thinking Dr. Guzman was joining us as well. Is she also joining us?
Dr. Guzman was unable to join us, so Dr. Ludke will be carrying the water today for both of them.
Well, we know that we can absolutely trust him to do that piece. So I'm just going to briefly introduce the item, and then I will turn it over to the Public Health Administrator and the Public Health Officer. This is our semi-annual opportunity to speak with you in your capacity as the Board of Health. Certainly the last 2 years, we've been meeting quite regularly as a Board of Health, but this item is different in that it takes that wide look at the larger community, both all of the work of Health and Human Services, but also gives you an opportunity as you sit in your role as the Board of Health to look at the larger health conditions in the community and your role in that capacity of really protecting the health and safety in the community. So this is our opportunity. We do structure these reports so that we give you a specific agenda item that we'll do a presentation on today. It will be around sexually transmitted infections in the community, and then attached to that report also an update from each of the divisions within Health and Human Services. While we won't give a presentation on those items, we certainly invite any questions that you might have from the written materials, and I'm happy to address any of those questions that might be pressing for you. But I don't want to take a lot of the time until Dr. Warren and hopefully Dr. Ludke, who I haven't seen pop up on the screen yet, do the presentation. We have about 30 minutes set aside this morning for presentation, and then 30 minutes set aside for questions and discussion from the board. There's Dr. Ludke. Excellent. As we launch into some structure time for you to really sit in your role, that foundational role of the health of the larger community. So I think I will pass it to you, Jocelyn.
Thank you, Karen. Thank you, Chair and Commissioners. Appreciate this opportunity to bring something other than COVID to the board. Obviously, COVID is still the most important thing that we are doing right now, and why Dr. Guzman is not able to join us today. That is one unfortunate aspect of the COVID response, is that although we have been able to hire multiple people in the response, our primary communicable disease staff are still often roped into the work because they are the experts. And so I also want to acknowledge that Dr. Guzman, as well as Michelle Hampton, one of our senior community health analysts, were instrumental in providing the background and the a lot of the analysis for the report. So much appreciation to them. And I will turn it over to Dr. Lutke to present. Thank you.
Dr. Lutke, you're muted.
Let's try that again.
Yes.
Thank you, Jocelyn, Chair Bernie, Commissioners. I also clicked on share screen. Are you able to see my screen?
Yes, we are.
Very good. All right. I was getting nervous that the preamble I heard from Commissioner Farr of his challenges with IT technology may have spread like a virus to me, but apparently we have it figured out. Wonderful. So I am going to speak about sexually transmitted infections in Lane County over the last decade. And I am going to focus on what we call the Big Four, which is, I guess, a sporting analogy brought into the sexually transmitted infection world. But it's the four diseases that we follow the closest that are of concern, both because of volume and because of over the seriousness of their health effects. And to begin with, I want to talk about those Big Four. I want to do a deeper dive into congenital syphilis, which sadly is something that has returned to North America, not just to Oregon and to Lane County. Do a deeper dive as well into chlamydia infections, and then spend the last couple slides discussing what Lane County Public Health is planning to do over the coming months to address the challenges with these sexually transmitted infections. So I have nothing to disclose in accordance with the American Medical Association ethics requirements, no stock ownership, no challenges in the ethical space with regard to what I am presenting today. And I too, as Jocelyn mentioned, want to thank several persons for the data that we are presenting today. First, sexually transmitted infections are reported to public health by our local clinical practices. This is a system. It's a system that we use for a variety of illnesses, from GI and respiratory to STIs. And a sincere thank you to the clinical practices for the work that they do to get us data in a timely manner. And then, as Jocelyn mentioned as well, Lane County Public Health staff, our communicable disease team, in particular, Dr. Guzman and Michelle Hampton, who work in the STI space every day and out in the community to help address the challenges that we see in this area. So a couple interpretation pearls. You're going to see some data, you're going to see some percentages. Keep in mind that in the decade up to 2020, our population grew 9%. We have heard on occasion in the media that the challenges with various diseases, whether it's an STI or an increase in salmonella, is because of a growing population. Yes, our population is growing, a bit over 1% a year on average, depending upon which 5-year or 10-year period you look at. But STIs are growing at a markedly higher rate than that. I also want to make a comment that no surveillance system is perfect. We have active surveillance and passive surveillance. It's a combination that we use to report this data to you today. And the data that you're about to see is really absolute minimum data. So there are a variety of reasons for that. I'll just touch on one right now. In the state of Oregon, as in many states, we have something called expedited partner therapy, where if a patient is seen and they have, for example, a gonorrhea infection, and they have a sexual partner, the doctor, the nurse practitioner can provide 2 prescriptions to treat the person who is before them and to take a medication home to treat their partner so that both are treated. And yet we will never get a test on that partner because they will be treated without a test. So surveillance data is the minimum number of actual cases out there. It's probably not the actual number of cases. Keep that in mind. And then finally, in terms of interpretation pearls, we are always torturing our data, as we say in public health, trying to see, is this worthy enough to be reported? Where are the biases inherent in data collection, data analysis, data reporting, and trying to get rid of those biases. And a big challenge in the last 18 months, has been a pandemic related surveillance artifact. If you recall, I think it was March 23rd last year, the governor essentially closed down society for a while. People didn't go to see their primary care providers. So of course, there was less testing, treatment, and reporting. Many people moved to virtual care, so there's less physical examination. So there have been some changes in the surveillance system over the last 18 months that we need to continue to tease out with regard to their impact and import. So that's it for the preamble. Let's move on to the data. I'm going to go through the big four one by one. I'm going to start with chlamydia. When we talk about chlamydia cases in Lane County, we talk about thousands of cases. When we talk about gonorrhea, it's hundreds. When we talk about syphilis, it's dozens. And as you can see on this chart, on the left-hand side, on the y-axis, you see cases increasing by 200 cases. And on the x-axis, you can see the years. And the dark red is female, and the salmon pinkish color is in males. And the line on top is those two added together, the total number of cases. You can see a slow but progressive increase from roughly 875 cases back in 2009 to around 1,200, 1,300 cases over the last few years. And then this drop off in 2020, which partly is surveillance. Fewer people went to see their doctors last year because of the pandemic. But that's the data that we have. But a progressive increase over time. And the challenge here is that there are thousands of cases of chlamydia. And as we do a deeper dive and further on in this talk, you will see why chlamydia is not just a small smoldering fire. It's a real challenge with regard to chronic infection and chronic impacts. But suffice it to say, the numbers have increased over time. More women than men, roughly a 2-to-1 arrangement in terms of more female cases of chlamydia than men. Part of that is regarded to surveillance. Women get pregnant as part of the general screening in the first trimester for all pregnant women who seek prenatal care. They will indeed be screened for chlamydia. So there is a bit of a surveillance artifact in this as well, which we take into account when we look at statistical assessments later on. Next is gonorrhea. You can see the gonorrhea trajectory has been pretty significant over the last half decade. When I moved here in 2010, we had less than a dozen gonorrhea cases confirmed, and we have had a significant increase over the last decade or so. On this slide, the counts are in the hundreds on the y-axis, and you can see the years on the x-axis, and the darker greenish color is male and the lighter is female. And the same line on top is the total number of cases. Significant increases. And the challenge that we have in Lane County that's a little bit unique is that across the country, there are more gonorrhea cases, significantly more in men than in women. In Lane County and in several counties along the I-5 corridor in Oregon, there are a larger percentage of women with gonorrhea than we see across the country. Also in Canada as well, it's more a male predominant condition similar to syphilis. We are routinely trying to tease out and better understand the demographics of this disease. And I don't think we fully understand it, but suffice it to say that there are more female represented with gonorrhea in our county in percent base than across the country. If you look at the age for all four of these, you can see that gonorrhea, or GC, that's one of the nicknames for gonorrhea, or the gonococci is where that comes from. GC in female is the Kelly green color, peaks in the early 20s. GC in males peaks roughly about the same time. That's the orange color on this graph. CT, or chlamydia, the genus and species of that bacteria is Chlamydia trachomatis, so we call it CT for short. CT in females is the gray. You can see the large number, again, peaking in the late teens, early 20s. And then Chlamydia trachomatis, CT in males, is that darker orange-red color, crimson-red color. Similar peaks overall in terms of the age and sex. If you take a look at HIV, first pay attention to the y-axis. Very few HIV cases. We average about 1 new HIV case a month, roughly a dozen a year, if you average it over the course of a decade or so. But you can see some peaks. Back in 2016, we had a single cluster of 5 cases of HIV. We discovered in about 6 weeks, which of course was really frightening to us. Did a lot of outreach work to stop that cluster, to stop that from spreading even more. But there were 5 new HIV cases. Again, roughly 1 a month in Lane County. The numbers are up and down, as often happens when you have small numbers. A single case changes percentages significantly. Something else I think that's worth noting about HIV is, of course, it's a chronic disease. After you're infected for life. And it can be a very costly disease. The Center for Disease Control did an assessment about 2 years ago of the lifetime cost of HIV care. It's about $500,000 just for HIV. That is a huge cost burden to our healthcare system. So although we think of 1 new HIV case per month in Lane County as a tiny number and perhaps easy to dismiss, it represents a huge sum of money over the lifetime of that patient. And of course, a good deal of suffering too with regard to requirements for ongoing healthcare and such. So we watch HIV very carefully and very closely. Any little blip, we jump on it, like in 2016 with that cluster of 5 cases in a short period of time. I'm going to finish the big 4 with syphilis. When I moved to Oregon in 2010, Lane County had, I believe, 8 cases total between male and female of syphilis, and a significant increase, as you can see, over time. Again, looking at the y-axis, when we talk about syphilis, we talk about dozens of cases, not thousands like chlamydia, and not many hundreds like gonorrhea. We talk about dozens of cases. Significant increases, look at 2019 and 2020. And as mentioned earlier, a fair number of women with syphilis in our county, different than other parts of the country, different than parts of Canada as well. I would mention Mexico as part of North America, but their surveillance system really is not quite good enough in many respects to get a good comparison. But suffice it to say, significant increases in syphilis in Lane County over time, and those numbers really add up. If you look at the state, we had significant problems with syphilis in our state in the 70s and into the 80s, and big drop-offs, as you can see in this graph down here, throughout the 90s. Not many syphilis cases. And then again, as we hit into the new millennium, large increases across the state, which is disheartening to many of us in public health, having lived and practiced through this time back in the 80s and 90s when we were treating syphilis pretty regularly. We were quite happy when we kind of were able to forget about syphilis for a while and the treatments and the staging of it. But it's back. Unfortunately, it's back big time. So I'm going to transition here into some of the deeper dives. And I think it's a worthy question. Besides COVID, what keeps public health professionals up at night? As you might imagine, there are many answers to that. There's the Cascadia earthquake. There's climate change. There's big outbreaks of salmonella and E. coli, other respiratory outbreaks like influenza and whooping cough. But you just saw those syphilis numbers. What's keeping us up at night is as soon as you see syphilis increasing at the rate that it did, and then as soon as you start to see syphilis in women, you start to see congenital syphilis. Unfortunately, as this slide shows, CS is congenital syphilis. Congenital syphilis has returned to Oregon, just like syphilis has returned to Oregon. And congenital syphilis is just a really, really sad fact these days. If you think of congenital syphilis from the public health vantage point, it's really a failure in so many ways. The initial failure is someone had unprotected sex and got syphilis, and they either weren't tested or they weren't treated. So that's the first failure. And then that person passed it on to someone else. Let's say it was a woman and she got pregnant and she did not get screened and tested in the first trimester, which is the recommendation for screening in pregnant women. She's also supposed to be tested in the 3rd trimester. That didn't happen and she didn't get treated. And then the baby is supposed to be tested at birth, and so was mom retested, and that didn't happen either. And then later on in infancy, we find a congenital syphilis case. So multiple failures in the public health system for a single congenital syphilis case. You can see most of the cases in Oregon at this time over the last 6 years are in the I-5 corridor. Lane County is represented there. If there's any good news on this slide, and I really don't think there is, but Lane County is about 9% of the population of Oregon, and we have 9% of the congenital syphilis cases. I guess that's better than Jackson County, which is about 6% of the population, and they have 13% of the cases. But it's hardly an area where we want to compare ourselves. A single congenital syphilis case is a massive failure in the public health space and in the clinical space. And I will say one more thing about congenital syphilis. These children can be affected for life. It does not affect lifespan. Most children, if they're infants, if they survive infancy, and about 10% die from syphilis. If they survive infancy, they will live to a normal lifespan, and they will have congenital malformations, cognitive issues for the rest of their life. So it's a real sad story. Early syphilis is up about 900% in Oregon women since 2013. And, keep in mind again that in Lane County, our population only increased 9% in the decade up to 2020. This is a real increase in syphilis. Early syphilis is a syphilis we want to find quickly so we can treat it before it gets passed to others. This graph is a little bit complicated, but if you look on the left-hand side, you can see cases of congenital syphilis. Again, the numbers are small. We're not talking about thousands or hundreds or even many dozens. We're talking about last year, 19 cases in the entire state. This year in Lane County, we have 4 already, which is far too many for just Lane County. And then this orange line here is the rate of early syphilis, showing it's increasing in tandem with the same curve shape as you're seeing with cases of congenital syphilis. And this is one of those issues that we in public health have been concerned about for some time. When we started seeing syphilis in women increase, we knew it was a matter of time before we would start seeing congenital syphilis. And sadly, that has proven to be true. So right before I was putting these slides together, the national data set for congenital syphilis was published just a couple of weeks back. So I included a slide from the New England Journal of Medicine with that data from the Center for Disease Control. And you can see, again, looking at the y-axis on the left side, we're looking at a couple thousand cases across the country. And these are the years that the decade, 11 years actually, from 2010 to 2011, or 2020, significant increase in congenital syphilis across the country. So perhaps there's comfort in saying we're not alone. The challenge is the public health system is not doing as well, neither is the clinical system, at finding syphilis, treating syphilis, and preventing congenital syphilis. We have a lot of work to do in this space. So the other deep dive I wanted to do today was into chlamydia. In many ways, chlamydia is sort of the minor symptomatic infection initially of the big 4. It can smolder relatively asymptomatic, especially in women, but also in men for weeks, months, even a year or 2 or 3 before it can finally cause problems. The challenge with chlamydia is it causes some really nasty things downstream. It can cause pelvic inflammatory disease. We have, oh gosh, every month we have a couple people hospitalized for pelvic inflammatory disease where chlamydia gets out of hand and marches up into the abdomen and causes problems. Even causes infection around the liver. It also scars the anatomy of women, the fallopian tube in particular, and can result in ectopic pregnancies, which is a pregnancy that is not in the uterus. The egg has chosen to implant somewhere else, and that can be an emergency because only the uterus is meant to hold the fetus for 9 months. If the fetus ends up somewhere else, it can cause rupture and bleeding and real problems. Chronic chlamydia infections, and because of the scarring especially, can also lead to infertility. Women may have had, especially women may have had a chlamydia infection in their teens or 20s, and then they try to get pregnant 10 years later and find that they're infertile. That is a fairly common cause of chlamydia. Chlamydia is probably the #1 cause of infertility in this country. It can also cause this interesting, at least interesting from a scientific standpoint, syndrome that results in a triad of symptoms. You get an arthritis that's unpredictable. It just comes and goes. You get this urethritis where, sorry for the phrase here, but it hurts to pee repeatedly. And then you have these eye challenges, this conjunctivitis. And this used to be called Reiter's syndrome. Now it's called reactive arthritis. There are several other names for it. But chlamydia can cause this as well. It can result in chronic pelvic pain in women. And in men, it can cause a chronic infection in the epididymis, epididymitis, which is an ongoing cause of pain and discomfort in men. So chlamydia is, not just an annoying discharge on occasion. It can be a real problem going forward. So a little bit more data when we tease out chlamydia and gonorrhea. Typically, chlamydia is more prominent in younger females. Part of that might be a surveillance bias, again, because women get pregnant and they get screened as part of their prenatal workup that we do in the clinical space. Chlamydia typically peaks in the early 20s. Gonorrhea is more prominent in males and typically peaks a bit later in the 20s and 30s. But when you put them on a graph on top of each other, they're only a few years apart in terms of their peaks. So it looks fairly similar. Here's a graphic of the big four looking across age. So gonorrhea is this darkish green color, the first one. You can see kind of that peak in the early 20s and a lot of cases and a slow decline. Chlamydia is next. You can see the turquoise bluish color, peaks a bit earlier, even into the late teens. And then again, a lot of cases, continues on. Syphilis peaks a bit later, 20s and 30s, pretty high levels into the 40s. And HIV, the numbers are kind of too low and sporadic up and down, but we see it across a variety of age groups. And because HIV can be such a chronic infection, people may not present for a decade after they're infected. So it's a bit harder to take a look at the HIV presentation by age. So I'm going to shift last couple slides here to our prevention efforts and what we plan to do, given the data that we have presented to you today. First of all, given the relative youth of several of these infections, we need to develop more media messaging and targeting for youth and for parents, and we are working on that now. Michelle Hampton is spearheading that work in our communicable disease program. We also need to get more testing and treatment done. There is a condition, a very common condition. It's called pityriasis rosea. I suspect that several people listening today have had that condition. I had it diagnosed when I was a kid. It's a fairly common skin condition, easily diagnosed. Unfortunately, secondary syphilis looks very, very much like that. And I have been telling the clinical community repeatedly over the last few years that we have seen a couple people with PR or pityriasis rosea diagnosed. It ended up being secondary syphilis. We have so much syphilis out there now, any rash a provider should consider, why is this not syphilis? And that's a part of the clinical messaging that we are working on with our primary care providers, or PCPs on this slide, and our pediatricians. We also want them to increase testing and treatment. The bulk of the challenges with, and I hope this is correct, with getting face-to-face care in a pandemic have been worked out with infection control measures and some virtual care, such that I hope that we can get back to regular testing and treatment of persons who are symptomatic with potential sexually transmitted infections. And that's what we're working hard to promote in the clinical community. We're also looking at targeted population outreach of those persons at highest risk, including persons who are houseless, men who have sex with men, other groups that are at higher risk. The incarcerated also, we're working with the Lane County Jail. We've had projects in the past that were successful. We're hoping to renew some of those in the days to come. Also, we had a Just Checking clinic at a prior Board of Health report. Cindy Morgan, our retired communicable disease nursing supervisor, discussed our Just Checking clinic. She started that clinic. It was a wonderful addition to the needs of our community. Unfortunately, the pandemic has caused us to reallocate resources elsewhere, and we're going to need to restart that clinic. Lane County Public Health needs to be part of the solution with regard to these massive increases in STIs in our community, and we are going to do just that. 4 other items we're working on for STI prevention to address these challenges. We need to increase the STI appointments. We thankfully have Dr. Guzman with more added appointments to her schedule, 20 hours each week as part of the STI work in her job. She also has worked on a PrEP clinic. I didn't discuss PrEP, but PrEP stands for pre-exposure prophylaxis. And PrEP is a medication, it's now 2 medications actually, that can prevent HIV in persons who are exposed. You may have heard about it for needle sticks. If someone in the healthcare space gets stuck by a needle, they can be put on PrEP to prevent HIV infection in them. So we can now use it for persons at risk for HIV, and we have a PrEP clinic, and Dr. Guzman is spearheading that. The last 2 items, we want to restart some of the STI collaborative work we have done in the community. For example, we had STI testing at Looking Glass, which because of the pandemic, and they went to all virtual, and we had challenges, and people reallocated. We're going to restart some of that STI testing in the community and work with the HIV Alliance as well in that work. And then finally, I believe at a former Board of Health report, we discussed briefly some opportunities for mobile outreach, including the vans that we're having retrofitted to allow us to do some mobile work in the community. And that mobile work will include some of our STI work. So I'm going to stop there. Those are the 8 items we're working on in the days to come to try to address these large STI challenges in our community. Happy to take any questions or comments. I also mentioned their criticisms or witticisms. We're happy to take it all. Chair Bernie, thank you for your time today. Back to you.
Thank you very much, Doctor. That's a pretty sobering report. Are there commissioners that would like to begin asking the doctor or the doctors questions or have your own comments? Yes, Commissioner Buck.
Thank you, Chair. We mentioned this in the beginning. All eyes still seem to be on COVID-19, and it's really hard to get people's attention for a lot of other really important issues. So how do we get that information out to the public that we can't forget about these other chronic medical issues that are ongoing in the meantime?
Chair Bernie, Commissioner Buck, I think it's a really good question. I'm happy to start. I'm sure Jocelyn and Karen will want to weigh in as well. We do have a bit of a toolkit in this space. We work very closely with the clinical community. We have the opportunity to get the message spread several ways. The clinical community is one. We really want to work with the media and have them magnify our message. And you're right. How does that message get heard when so many other messages might be COVID or public unrest, et cetera? But we do leverage the media a great deal. And then that targeted outreach to high-risk groups is really a public health tool that is tried and tested. You can't really boil the ocean, right? So you have to focus on where the highest risks are. And we really do work hard focusing on those groups that are at highest risk. So that's another opportunity. Karen, Jocelyn, other things to add?
I would be happy to add something. Thanks, Dr. Pat. There have been a couple of good things that have come out of the pandemic because of the focus on public health and funding. And one of those things Dr. Ludke mentioned was the mobile units. And I do think that that's going to be a really great asset for us to be able to really engage more with community around Lane County and not just kind of compelling people to come to our clinics here in the metro area. The other thing I think that we've really acknowledged over this pandemic is the role of communication. Commissioner Buck, I do think that that is incredibly important. That is not something that public health has necessarily been funded for directly in the past. That is changing with what we call public health modernization, and there is additional funding, and we are adding particular communication-focused staff for that very reason, and I am really excited about the potential for that. We have an excellent PIO in the person of Jason Davis, who is able to respond very adroitly to emerging news issues as they come up, but we also need some kind of comprehensive strategic planning around communication, and there's a lot of best practices in public health that we are looking forward to implementing here locally with new staff.
And Chair Bernie and Commissioner Buck, if I might add just one other piece, I think as I think about your role as the Board of Health and our local public health authority, I think that how we move that conversation out into the community goes beyond only what our public health staff can do with their funds. I think about each of you as ambassadors for health in the community. So I invite you, as we hopefully are creating a little bit more bandwidth as our pandemic caseloads go down, to lift up the areas that are in our community health improvement plan that really point clearly to strategies to improve public health and community health. Many of those you talk about, top of mind is housing and homelessness, for instance, is a core public health issue. And so I think there are things that the board can do as our board for the local public health authority to lift up those issues. Think about the strategic planning that the Board of Commissioners is entering into in earnest right now of how do we make sure that those issues that are critical to health in the community are reflected in all of the work that the county does to really help create that context for the specific work that our public health team can do.
Apparently with every commissioner question, there will be 3 answers. So because we have 3 professionals here that know their stuff, Commissioner Trieger, you used to have your hand up. You're muted, Commissioner. Nope. I know Commissioner Trieger will be joining us momentarily. If this takes too long, other commissioners are more than welcome to ask a question. And anyone else? Yes, Vice Chair Farr.
This is a filler question. You know, we know about public health in the jail. People have been incarcerated. We have an issue there that, of course, they aren't able to bill Medicaid in the jail. And I believe this is a public health issue. Not much to talk about right now, but I want to flag that as a point that we do have a lot of people in the jail who not only suffer from physical health issues, but behavioral health issues. That's an ongoing conversation. And hopefully by now, Commissioner Trieger's back in, so I don't have to fill in any longer. But that is an important discussion item.
That was important. It's certainly not filler, Vice Chair, but yes, Commissioner Trieger.
Thank you. How's that?
Perfect.
Yay. Thank you. I caught the tail end of what Commissioner Farr was saying, and I appreciate the comments about healthcare in the jail and the financial challenges there. I think is what I caught hearing about that. Thank you so much for your presentation this morning. The Commissioner Buck's question to me gets at the difference between messaging and communications, right? There's communication channels. How do we get the information out? But there's also what are the messages and how are we framing this issue? And when I was looking at your slides, Dr. Ludke, I couldn't help but notice there's a particular gendered aspect to our sexually transmitted infection rates and their impacts in our community. That chlamydia by far has the most cases, and that it is more women that are affected. And so I'm wondering if there are specific efforts, whether it's around that messaging or that outreach or community partners. You mentioned, right, clinical spaces and primary care docs. You mentioned Looking Glass for reaching youth. I'm wondering about partnerships with community-based health centers, or school-based health centers, or other partnerships that are particularly and especially getting at addressing the unique needs and impacts on women in our community and maternal and infant health.
Chair, Commissioner Trieger, Chair Burney, I'm happy to start with this one as well. So one area of opportunity, I believe, is with our OB-GYN groups. So Women's Care and Pacific Women's. We have tried over time, over years, to develop a better relationship. Not that it's bad, just that it doesn't exist. Surgeons are busy, and you know their job is 24/7. They sometimes have to do surgery at 2 in the morning. That's just the way it is. So we have some initial outreach with our larger OB-GYN groups to try to carry that message, not just for existing patients, but to get patients in earlier. I didn't share the deepest dive on congenital syphilis, but as you might imagine, a fair number of those congenital syphilis cases were in women who had zero prenatal care. There's a huge opportunity there, and we really need to work better with the OB-GYN space. So that's one big opportunity. Happy to pitch it to Karen or Jocelyn.
I'm happy to just supplement that. We do have, I really appreciate the mention of school-based health centers. I do think that's a great opportunity and one that we're hoping to engage in more with as COVID begins to ebb a bit, because those staff that would be dedicated to that right now are preoccupied with COVID, but we are hoping to also implement an HPV vaccine campaign, which would also be definitely targeted for preventing a lot of cancers among women, but of course, targeting not just women. Of course, men are also really important in that campaign, or boys.
Great, thank you. That was one of my other questions, was the HPV vaccine and screening for chlamydia, because I think there's a correlation between HPV and chlamydia rates. Is there not, Dr. Lidke? Am I?
So HPV is, by far the most common sexually transmitted infection. I've forgotten the number of millions, but it's over 10 million per year in this country. It's a huge number. And it's transmitted the same way. So there are relations between the two of them. And just as any one STI can increase the risk of others, we've seen that especially with, say, syphilis and HIV. If somebody has syphilis, they're more likely to get HIV. It's the same with chlamydia and HPV, that there's a link. So yes, indeed. And it's just HPV, there's so many infections. It's not reportable, so I can't tell you how many there are in Lane County, but I can tell you there's a lot of them.
Great, thank you.
Thank you, Commissioner. Other commissioners? Yes, Commissioner Bozievich.
Thank you. And I want to try and bring this up delicately because I know this is a sensitive issue. Relative to my past questions about healthcare and racial disparities. But it seems as we see this rise, and particularly in syphilis, that it coincides with the changing demographics in Lane County and the possibility of the increase in human trafficking we're seeing from over the southern border with organized crime and a population that is kept away from medical information and possibly not interacting with our medical system. Are you seeing any sort of demographic differences in those statistics relative to certain populations, or is that a broad, the data you presented, is that broadly true for for all populations?
Commissioner, I think it's a very good question, and my response is really not going to be heartwarming to you. I don't think our data details in the demographic space is deep enough to give you a yes or no. We get disease reports, we get birth dates, and we get sex most of the time, but we have very limited demographic data. So unless we go out and do the case investigation, contact tracing, and one by one get the demographic data, we don't have it. We continue to work with our clinical community to see if we can get more demographic data. But as you might imagine, they're all pretty busy. And we're pretty darn happy just to get the test result from the laboratory and sometimes get reports from nurse practitioners and docs. But our demographic data is lacking, and that's an area of real opportunity.
So knowing that, are we making a lot of effort maybe to outreach on education in Spanish and other languages to try and reach some of these demographics? That's some of my concern, is just trying to do some preventative work in those communities.
I think I will let Jocelyn handle that one. We are doing some work in that space. I think Jocelyn has that on the tip of her tongue more so than I do.
Mm-hmm. Thank you, Dr. Lidke. Commissioner Bozievich, our most seasoned disease investigation specialist is bilingual and bicultural and is able and does investigations in both Spanish and English. We are hiring additional disease investigation specialists who are also bilingual. So that is absolutely, that's a focus for any public health service, is that we make those services available in as many languages as possible, but certainly Spanish is the primary.
Excellent.
Okay.
Thank you.
Thank you, Commissioner. Yes, Vice Chair Farr.
Thank you, Chair Bernie, and thanks earlier for allowing me a little bit of a filler item. I won't go back to that. Dr. Lidke, thank you for the presentation on STDs. This has been an area of focus and attention that you've alerted me to since the day that I met you, and I appreciate this relatively lengthy report on STDs. And and Ms. Gaffney, you mentioned that we do focus on a single particular item for the report, and then you add other reports into the written material that's given to the board. And if I may, I'm just going to deviate from STDs for a couple of quick questions. don't require long answers on this. Throughout the COVID epidemic, we've learned to use teleconferencing pretty well. And I think we've expanded telehealth fairly well. At some point, I wonder if we could have a presentation on how that has fared, the results, and if we have any data regarding the effectiveness of telehealth, both physical health and behavioral health. I think we've really kind of dug into that area quite a bit. I've always thought there's a great deal of opportunity, particularly in the outlying communities where people aren't able to drive into where the services typically are held. And ORCID has certainly done a superb job of expanding our outreach, but there are still a lot of people who have difficulty for one reason or another, physically attending an appointment. So if you want to respond to that briefly, I don't need a long response at this point.
Thank you, Chair Bernie and Vice Chair Farr. I would love to bring that topic back. I think we have learned a lot, both in the physical health clinical space and really significantly in behavioral health, about how using a combination of telehealth with in-person visits really can address some of the long-term access issues and barriers for people to access services. So I would be happy to bring that back at a future date.
And I will be patient in waiting for that, because there's a great deal of research that goes into giving it a good and accurate report. The last thing, ever so briefly, Chair Bernie, and I'm just going to say the two words that are really important to all of us, because we hear about it, whether you're in a homeless camp, whether you're in the jail, whether you're in schools, behavioral health issues. A very short report on behavioral health here. We talk about it quite frequently, and our adult outreach outpatient programs are expanding. Once again, Chair Bernie, we talk about behavioral health a lot. This is not the time for me to dig into depth on that. Just to, I guess, remind us all that it is probably the biggest flag in the avenue of flags.
Thank you very much, Vice Chair. It seems that all of the charts that Dr. Ludke shared with us also relate to behavioral health, or behavior at least. So Dr. Ludke, the last item you asked for was witticisms. I have no witticisms, especially after that report, but I do notice that there seems to be a causal relationship between when gonorrhea and syphilis started skyrocketing and your move to Lane County, approximately 2010. Is that correct? Do I have that data correct, sir?
Yes, and I've been fighting for my job ever since.
Okay. Forgive me. I know this is my more serious comments, if I might. We talk about and congratulate ourselves in getting some things out bilingually. Obviously, in other areas, such as the area my business was in before this, Los Angeles County, the number of languages people would get information out exceeds 40. It's a function of who's there and what languages are their native languages. Are we not it seems that we are at there's so much complexity. One, it seems to me that the profile of what Lane County Public Health does, its portfolio of work, if you would, these days is overshadowed by debates over to vaccinate or not to vaccinate, which all 5 county commissioners have been vaccinated and believe in getting vaccinated, or debates over should vaccinations with certain populations be mandated by employers as per federal law now, and various state laws. And we as a county find ourselves responsible for implementing laws that we did not develop, but nonetheless, I see gonorrhea, syphilis, HIV, all these other activities in the public mind being drowned out by debates which aren't necessarily that fruitful. They do rile people up, but they don't focus on solutions. So just a comment, I really think it's important for the profile of what Lane County Public Health is involved with, which is beyond the pandemic of COVID, to be a little more front and center. I don't know how to do that. I apologize. I just think it's important because when Ms. Gaffney talks about the role of commissioners. Well, the role of commissioners relates to the audiences we can get, who we can communicate with, and what's on their minds, and what they bring to the table also. So I just feel it's really important to do that. And another question: are we not yet at a point where we can immediately translate answers in different languages vis-a-vis the internet remotely when young people or not so young people have questions, and whether they speak English or another language? We're not at that ability where they can just type it in, and whatever the language is, it can be responded to, so that language barriers aren't so much of an issue.
Chair Bernie, I'd be happy to address the on the services side. And we do use a service called Linguava, and one of the kind of other nice things that has come out of the pandemic response is the ability to use Linguava via iPad or telehealth, services as well. So they do a range of services, which is fantastic. I wouldn't say they cover every language, so we do once in a while come up against something that is unusual or very difficult to do. But yes, absolutely. I worry about people just Googling sexual health information, because just like COVID, there is a lot of misinformation out there. But for one-on-one services, we can provide that translation.
So that's a silver lining, if you would. No, that's really cool. And especially if we don't recommend our population Google it, but they go to the Lane County public, the sites that we provide them for information. Thank you very much for the report. It's kind of overwhelming. And it kind of talks about the need for information enabling personal responsibility also in terms of our own personal health, which aggregates right into public health. Doctors, Ms. Gaffney, is there anything else you would like to share for the good of this understanding of these topics?
I don't believe we have anything else today, Chair Bernie. Just deep appreciation for the work that you all continue to do in collaboration with us and community.
Well, before you leave, because we don't often get expertise at your level with us at the same time, commissioners, are there any other questions for any of the panelists before we move on? Yes, Commissioner Trieger.
Thank you, Chair. Just a quick question. Pardon me. I thought of it when Commissioner Farr was requesting a particular topic come before us. How do we determine, because public health is so all-encompassing, it impacts all of us, and there's a lot of work happening all of the time. How do we determine what the topics are that you will bring back to us during the semi-annual reports? I have thoughts. I'm curious how that's determined and the best way for me to weigh in on what I'd like to hear during these reports. I know you're all very available and accessible to me for individual conversations about issues, but as a board, how are we juggling the many issues with the limited time that we have with you?
Chair Bernie and Commissioner Trieger, I'll start, and then I'm sure Jocelyn will have some more detail. I would say there are two ways that we determine the kind of deep dive presentation for these. One is Jocelyn, as the public health administrator, really is always looking at what are the emerging and critical issues for us to present data to the board. So she always has a suggestion of what it is we should focus on. And then the other piece is directed by the board. We pay very close attention to the direction from the board when you're identifying future items that you're interested in, and those, depending on the timeliness of them, they might come back as part of a semi-annual report. We've done that a number of times on preparedness items and other things, or we might bring them back more quickly than the semi-annual report. Like off the top of my head, I think the polystyrene issue was one, for instance, that the board had an interest in, and so we brought that information back before it was time for a semi-annual report. Jocelyn, is there any deep process you use as you determine what those items are?
Thanks, Karen. Commissioner Trigger, we have typically huddled as a leadership team with our epidemiologists and Dr. Pat and Dr. Guzman, our health officers, to discuss what the emerging issues are. We also like to do something of a high level to reset, to be able to provide kind of overall health status information. Dr. Lubke and I in the past have had a series of presentations looking at health outcomes over the life course in order to provide some context for the work that we do. We've also had focus items on modernization and accreditation, kind of those really larger issues that impact public health and the health of our community. And we are absolutely happy to take requests. That would be very welcome in the consideration for those, for sure. And we are happy to come back anytime to present on specific items. Thank you.
You better watch out. I heard Commissioner Trieger say she has ideas. Any other commissioners? I know some of you will be with us for our next item, but thank you all so very much. We are now on the last item of our joint meeting of Board of Commissioners and the Board of Public Health, report and discussion on tobacco licensing, SB 587. And we have with us again, Karen Gaffney, Dr. Warren, and I believe Dr. Elizabeth Maxwell.
So, thank you, Chair Bernie. And again, I will take just a moment to tee this up and then pass the presentation on to other staff. We have a fairly brief presentation today and are interested in general feedback from the board that then can direct future action. We want to review with you some real success that came out of the last legislative session, I think in part driven by the great work that happened here at Lane County, and then get some direction from you about the future of our local tobacco retail licensing rules in Lane Manual. So Dr. Warren, are you next? I don't see Elizabeth, so I'm assuming maybe you're doing this.
Thank you, Karen. Yes, Chair Bernie and Commissioners, I will be leading the presentation today. Dr. Maxwell was not able to be here, but I believe she has equipped me well in the presentation, and also Natalie Taylor, our other tobacco staff, are in communication. So we will, I don't think that this one will be too complex, and I'm really happy to be able to present this, though I think when we talk about public health and our kind of what our community approach and what the community now recognizes us for, a lot of that focuses on acute communicable disease right now. But I think the real heart of public health is prevention. And this is where the tobacco work really shines and where this board has been very active. So thank you for your support of that. And I believe Diana Jones is going to share my screen. Diana, are you able to bring that up?
Yes. Jocelyn, it looks like you're already sharing your screen. Hold on a second.
I don't think that we see it that way.
We're seeing your screen, Jocelyn. You're the presenter and you selected yes.
Okay. I apologize. I don't see it that way on my screen. So that's fantastic. Yes. All right. So I'll advance.
So Dr. Warren, all that means is you don't see things the way we do. That's all.
I like to think that that's not true. Thank you, Chair Bernie. So just a little background. The Senate Bill 587 this year was passed that required the Department of Revenue to issue licenses to qualified tobacco retailers across the state. The Department of Revenue will begin issuing licenses December 1st. That is their current plan, and hopefully that they will remain on target with implementation on January 1st. The OHA developed, that's Oregon Health has developed this tobacco retail license in collaboration with a lot of counties throughout the state that already have tobacco retail licensing in place. And the features of the Oregon Health Authority TRL is yearly compliance inspections, yearly minimum legal sales age inspections, that's for underage sales. And they also create a mechanism for filing complaints and then create a plan for remediation when those violations do occur. Lane County's tobacco retail license mirrors those aspects in many ways. We adopted the tobacco retail license in 2015 and unincorporated Lane County. In 2016, Veneta also joined our tobacco retail license program, and then in 2018, Crestwell also did. The one difference between our tobacco retail license and that proposed by the state and the Senate bill is a 1,000-foot buffer between retailers and a school, which is included in our tobacco retail license. The current enforcement here locally, the current retailer license is $200. Environmental health section of public health issues those licenses and does the inspections. There have been no minor inspections though conducted by us. The state occasionally does the minor inspections, but that is an area that could be absolutely improved. The other tobacco retail licenses that exist in Lane County are in Eugene, Springfield, Cottage Grove, Oak Ridge, and there are no tobacco retail licenses in Junction City and Florence. So the benefits of having, oh, I'm sorry. I'm not moving around enough. The benefits of having a state-administered tobacco retail license is obviously the opportunity to have one clear, consistent infrastructure, not only across Lane County, but across all counties in Oregon, which is a huge benefit for those that have retail sites in multiple counties. There will be yearly minor inspections, and also a mechanism, a regular inspection, a regular complaint mechanism that will be managed by the Department of Revenue, and also a mechanism for remediation of those violations. And then the Senate bill also allows for local jurisdictions to pass future restrictions. So it doesn't limit only the tobacco retail licenses to those just aspects that we already discussed of the tobacco retail licensing. You can also, because there are other counties that have additional provisions, which include flavor bans, price discounts, for example. So the next steps are that the Department of Revenue and the Oregon Health Authority have started communicating with those cities that already have tobacco retail licenses and whether or not they want to adopt the state TRL. And if they do, those same provisions that are in the state TRL must also be adopted by the city that is enforcing those. So undecided, as far as we know, at this time are Eugene, Springfield, and Cottage Grove. These other jurisdictions are adopting the Senate Bill 587 provisions. What we would like to do, what we are recommending is the staff prepare an ordinance to eliminate or alter our lane code for the tobacco retail license, and then assist in retailer communication about the state changes that will be coming, and that their relationship for this new ordinance will be directly with the state and the Department of Revenue rather than Lane County. We would also like to continue working with the other cities as they decide what to do with their tobacco retail licenses, because we do feel strongly that it would benefit the whole county as well as the state to have one county-wide TRL. One thing I would say is we can also easily adopt the 1,000-foot provision that would separate new tobacco retail establishments from schools. We've had discussions with the Department of Revenue, and because that is something that would be evaluated with an initial application for a tobacco license, the Department of Revenue could easily assess whether that location was within 1,000 feet of a school and accept or deny the application based on that provision. So I think that it would strengthen the TRL here in Lane County to also include that provision, and would be a minimal disruption to existing tobacco retail license holders. So that is the end of our presentation. And so our ask is for direction around whether the board supports our adoption of the state tobacco retail license provisions, and with the inclusion of the 1,000-foot barrier, as well as directing staff to work with cities that already have existing TRLs to make a transition if they decide they want to do that.
And Chair Bernie, I would just say, as we pass it back to you, obviously we don't have an ordinance in front of you today, so you aren't making the final decision on whether or not to change lane code, but it would be helpful to us if there's a general sense from the board that you'd like to proceed that way. The next steps would include us bringing back for first reading an ordinance to make those changes to lane code, and then of course we would schedule a second reading in action.
Yes, understood. Are there commissioners that would like to weigh in on this? I'm sorry, did I see your hand, Commissioner Trieger? No, okay. Any commissioners? Yes, Vice Chair Farr.
Just a single sentence. I support proceeding with the ordinance if an ordinance is what is necessary to try to to encourage a uniform code throughout Lane County to match the state's code.
Thank you, Vice Chair. Anyone else? Yes, Commissioner Buck.
I'll offer my support for the same. Thank you for the info and the update.
Commissioner Bozovich.
Thank you. And I'll just echo that I support staff's recommendations around this. I remember when we were implementing this, one of the concerns was the patchwork of licensing across the state for retailers like Dairy Mart that are in multiple municipalities and counties. And getting a statewide system, I think, will help some of those retailers to adhere to the law and have a consistent set of rules.
Thank you, Commissioner. Commissioner Trieger.
Thank you, Chair. Thanks for the presentation. I'm also fully supportive of whatever we can do to make as seamless as possible statewide, but I'm also very interested if there are additional future stronger restrictions on some of those issues you mentioned around flavored products and so on that we might move locally. And I'm also curious if the public health modernization provides some additional resources or increases our capacity to do inspection and enforcement at the local level so that we're building relationship with our retailers in a way that ultimately and eventually, ideally, creates better compliance for the long run than relying on state inspections, which are probably less frequent and don't have that opportunity to build local relationship.
Commissioner Trigger, I'm happy to answer the question about modernization. Thus far in the allocations for modernization and the work plans that have been developed have not included tobacco outreach. There have been really focused on the communicable disease section and are now including environmental health and development of climate action plans, which is very exciting. But I do think that some of the expansion and kind of larger thinking around what environmental health is and what they can do in a community, there is certainly a lot of overlap with working with our community partners. And our environmental health specialists, for sure, have developed really great relationships with businesses in town. And I agree that we do want to continue working with them around tobacco prevention in order to have a more robust system and better relationships. I think we can all agree that prevention of tobacco use among minors is something we are all interested in.
Well, I can tell you, Dr. Warren, it absolutely does not matter what I think. You have your direction to move forward. Although, you know, when you bring up that topic, there's another context here. It wasn't in the paper only today that one of the agencies for environment has identified 50 sites in Lane County that have forever chemicals exposed to people. I think we gotta we also need to prioritize some of this stuff. That could be a big deal. I don't know anything other than the headline. I don't know the depth of the data, right? Because there have to be some differences in exposure levels, risk factors, et cetera. But anyway, I'm all for it. You got what you want. go forth. We look forward to seeing the ordinance so we can vote on it. Thank you very much for the report.
Thank you.
Thank you.
I am now adjourning, we are now adjourning the joint meeting of the Lane County Board of Commissioners and Board of Public Health. And we actually are now beginning the Tuesday, November 2nd, 2021 regular meeting of the Lane County Board of Commissioners. Mr. Mokrahysky, any adjustments to the agenda? No? Any emergency business? No. Commissioners have already responded to public comments. Do I have a motion to approve the consent calendar for today? Yes, Vice Chair Farr.
Chair Bernie, I move the consent calendar of November 2nd, 2021.
Thank you. Is there a second?
I'll second.
Thank you, Commissioner Buck. Is there discussion to the motion? Seeing and hearing none. All those in favor of approving the motion made by Vice Chair Farr, seconded by Commissioner Buck to approve the November 2nd, 2021 consent calendar, please signify by saying aye.
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 Opposed? Let the record show that the consent calendar has been approved unanimously, 5 votes to 0. Thank you, Commissioners. We are now on item 5, Sheriff's Office, Order 21-11-02-03, in the matter of accepting a community-oriented policing services grant to provide $200,000 in funding for training in de-escalation tactics for law enforcement personnel, and delegating authority to the county administrator to sign the grant award. And we are delighted to have with us Sheriff Harold, Lieutenant Moore, and Sergeant Cleveland.
Thank you, Chair Bernie, and good morning, Board. Super pleased to be able to bring this information before the Board. Requires Board action because of the amount, the dollar amount of the grant, but very pleased to let you all know that we received this grant. Our organization has been focused on providing de-escalation training since 2018. That's when we first sent some of our staff to a training course to become trainers in de-escalation. And we've sent staff in 18, 19, 20, and 21 so that we have instructors within our organization to provide this valuable training. Because it's recognized nationwide, the importance of de-escalation training in law enforcement, the United States Department of Justice opened up a grant process specifically to provide funding for de-escalation training. We applied and were granted this $200,000. So what that enables us to do, even though we had already started on this work, our staffing margins are so slim that in order for us to really be able to provide staffing to our sworn staff members, it really requires overtime coverage to make sure that the shifts are still covered. And so this is $200,000 over the next 2 years to be able to provide de-escalation training to every sworn member of the Sheriff's Office. And it allows us to pay the overtime for the shift coverage while folks are in the training. I do have Lieutenant Moore and Sergeant Cleveland here in case you have any specific questions. They're much more subject matter experts on what the training consists of. But that's the gist of the message that we wanted to bring. And of course, looking forward to receiving this grant and utilizing it.
Lieutenant, Sergeant, Sheriff, thank you. This is a big deal. So congratulations. I'm presuming this body approves this. Are there any questions for any of the members who are here with us today, or comments? Yes, Vice Chair Farr.
Thanks, Chair Bernie. I'm prepared for a motion whenever you're ready, but first a question for the Sheriff, Lieutenant, and Sergeant, perhaps. Regarding the training, Sheriff Harold, I know and you've stated that de-escalation training has been provided for all sworn officers. That's both inside the jail, patrol, all sworn officers. Can you give me an indication as to the frequency that the training is used on the job? Is that a daily occurrence, do you suspect?
I absolutely would say that it's a daily occurrence. And I just want to clarify, this grant will allow us to make sure every sworn staff has been through this specific de-escalation training. We've been engaged in the work since 2018, but we haven't accomplished having every sworn member get through it. And this grant will allow us to do that. But certainly deputy sheriffs are engaged in de-escalation multiple times daily. That's really what our job is. The mission of our office is to conserve the peace, and that requires being able to communicate well and de-escalate situations in order to conserve the peace. So yeah, it's really important training. We've known that for a while. There's been additional emphasis nationwide. Our state legislature actually enacted some additional police reform bills that really codify the requirements to de-escalate, and in particular inside of our jail facilities as well. Our jail commander, Clint Riley, has been the chair of the Oregon Jail Managers Association in this past year. And frankly, our facility has really been a lead in the state in de-escalation and in getting that information into our policy and practicing it.
Thank you for that, Sheriff, and thank you, Chair Burney. I'd just like to take a second to thank you, Sheriff, and also thank Captain Riley for the tour that you provided for me and City Councilor Randy Roves on Friday of the jail. We spent a lot of time talking about behavioral health issues, as you recall, and there was a member of the public, Rich Locke, who joined us, who had some great questions, and you provided great answers on that day. Thank you very much. Thank you, Chair. I'll wait for your signal for the motion.
Thank you. It's going to be a secret signal. Before we entertain a motion, I just wanted to ask Lieutenant Moore or Sergeant Cleveland, in that Sheriff Harold identified you were subject matter experts, if there were any insights as to the impact of this you're anticipating?
Yes, thank you, Chair Burney. As you know, we have a very high rate of folks in here with mental illness, and de-escalation is paramount to communicating and de-escalating multiple times a day when they're in a crisis situation, whether it be in booking or in a housing area. This grant is going to go a long ways to assisting us with that on a daily basis.
Thank you, sir. Sergeant, anything?
Thank you. I just want to reiterate what the sheriff and the lieutenant said. We've trained close to maybe 150 deputies since we started doing this. Some of them have actually gone on to be transferred to our police services section. So they've taken that training with them into their new assignment. All of the deputies that are currently working inside the jail have received the training, and it's also part of our new employee training program. So when we hire new deputies, we teach this to them right off the bat. So it's a great thing to have here, and it's worked very well in reducing the number of use of force incidents that we've had to deal with over the past few years. Thank you.
Oh, no, thank you. I think it's really insightful for this body to understand the significance. Actually, I thought a call for motion, but no, Commissioner Trieger would like to make a, Commissioner Trieger.
Thank you, Chair. Yeah, the sergeant's comments just made me think I want to appreciate Sheriff Harold and I had a good conversation last week. And I'm just thinking about how this is really important for the community that we serve, and to make sure that people are being treated in a way that helps them on their path to recovery and reform. But it also makes for a better working experience for our staff, and helps staff feel more productive and able to perform their, it just gives them more tools to do their job. And the sheriff and I talked a bit about how important that is because of the challenges and the kinds of issues that our deputies are faced with, particularly in the jail, but also in the field. And that they deserve to have this training as part of their own professional development, and to have a better work experience. And hopefully that means stay on the job that much longer with Lane County. So I'm fully supportive of this and appreciate the presentation. Thank you.
Thank you, Commissioner. Vice Chair Farr, I think we're ready for a motion, if you'd be so kind.
Thank you, Chair Burney. I would like to move Order 21-11-0203 in the matter of accepting a community-oriented policing services (COPS) grant to provide $200,000 in funding for training in de-escalation tactics for law enforcement personnel and delegating authority to the county administrator to sign the grant award.
Thank you, Vice Chair. Is there a second?
I'll second.
Thank you, Commissioner Buck. Vice Chair Farr has moved. Commissioner Buck has seconded approval of Order 21-11-02-03. Is there further discussion to the motion? Seeing none, all those in favor of the motion, please signify by saying aye. Aye.
Aye.
Opposed? Let the record show that Order 21-11-02-03, moved by Vice Chair Farr, seconded by Commissioner Buck, has been approved unanimously, 5 votes to 0. Sheriff, Lieutenant, Sergeant, thank you very much.
Thank you, Board.
It's my understanding, Mr. Dingle, there are no announcements from County Council today, but I better be sure. Are there any announcements? That would be enough.
No announcement. No, I'm sorry. There's no announcements.
Oh, and I'm sorry. I thought you might not be here. So thank you very much. Didn't mean to jump over you. We're now on item. Well, actually, we now have the ability. We're on schedule. This is a first. I know, Mr. Mokrahysky, you're going to make some announcements, but we are able, with the board's permission, to move into executive session this morning instead of this afternoon. But I'm sorry, Mr. Mokrahysky, please go ahead.
I wanted, thank you, Chair. I just wanted to sneak in a quick announcement that's relevant for this morning. So certainly the board can go into executive session. For the public not joining executive session, want to remind folks that we have a strategic planning community forum scheduled today at 11:30. It's a virtual forum today at 11:30, tomorrow, Wednesday, November 3rd at 5:30 p.m. and then Thursday, November 4th at 6:30 p.m. And you can find the link to those community forums if you go to lanecountyor.gov/strategic plan. And then just click on tell us what you think and you'll get a link to those community forums. So just wanted to remind folks today at 11:30, Wednesday at 5:30, Thursday at 6:30, we'll have those strategic planning community forums. Really important to get feedback from our residents as we begin the process of developing our new plan for the next 3 years. So thanks for allowing me to share that with you.
Well, thank you very much on behalf of those listening. Diana, if you would be kind enough to read us into executive session. And before you do, it's 10:54. So after we are read in, let's convene at 11:05 in executive session.
Thank you, Chair Bernie. I will lead us into executive session. This is executive session for Tuesday, November 2nd. The Board of County Commissioners will meet in executive session to consult with counsel concerning the legal rights and duties of a public body with regard to current litigation or litigation likely to be filed. This executive session is held pursuant to ORS 192.6602H, which allows the Board of Commissioners to meet in executive session for the purposes listed. Representatives of the news media and designated staff shall be allowed to attend the executive session. All other members of the audience are asked to leave the room. Representatives of the news media are specifically directed not to report on any of the deliberations during the executive session, except to state the general subject of the session as previously announced. No decision may be made in executive session. The Board of Commissioners reserves the right to come back out into public session should the need arise.
Thank you very much. We will convene an executive session at 11:05. Thank you, Commissioners.